can we have a consensus guidelines? Okay, we started the patient, as Dr. Jibrin said, for ulcerative colitis, our society, mild, moderate, we usually go with 5-ASA or a short course of steroids is doing very fine. Professor Federak said for Crohn's disease, we should hit hard. And as our registry seen by Dr. Abdurrahman Jibrin, they are younger patient, Crohn's disease, hit hard with 3 modulators. What is your stop rule, consensus between you? How do you, apart from mucosal healing, how do you stop your biologics? Especially our patients are young in Crohn's disease, and we are afraid from TB and these malignancies. So, Professor Federak?
Excellent question. So I really believe that we need to be more aggressive than we've been in the past. You need to moderate that with the risks, the TB. You need to deal with all of that up front. I still think, though, that profiling is really important. You identify that the high-risk profile, you need to be aggressive in your treatment, as I've identified. That's in contrast to someone with Crohn's disease who may have a very short segment, 1 or 2 centimeters, stricturing Crohn's disease. That patient may do well with some surgery. And so we didn't talk about that. But profiling is really important. And if you profile to those high-risk groups, I think you need to follow through with advanced, accelerated, aggressive therapy.
Yeah, what comes out of the risk discussion is that an inconsequent therapy probably is the biggest challenge for your patients. So you're better off by putting a patient on anti-TNF, for example, if the patient does well, even a monotherapy for quite a while, and continue it, than to change the patient to prednisone, azathioprine, anti-TNF on top, and at the end have all the agents in there at varying amounts and concentrations. So that's the worst thing for the patient. So keep the disease under control, and then to obviously come up with a long-term strategy.
So when do you stop biologics? What is your consensus? When do you stop?
So I don't have any stopping rules. I'm continuing. I tell the patient forever or indefinitely. I recognize, though, that new science is going to give me stopping rules in the future. So,
yeah, we do the same. We also continue the patient forever, but the patient usually doesn't like that. So I tell the patient, you know, we can look at your intestine, we can look at your inflammation, and you've seen the story trial. Professor Panis has shown, as long as there's still inflammation in the intestine, as long as there's still endoscopy showing findings, as long as there's still inflammation on the laboratory, the patient will relapse very fast after stopping anti-TNF. So, you know, that challenge I can offer the patient, I can investigate, and then I continue in most cases.
Professor Barnes?
Yeah, I agree. I don't think we have any clinically reliable predictors of patients at risk, and usually patients that still, most of our patients that are now under anti-TNF therapy come from the old accelerated step-up approach. So those are patients that had really a rough course of the disease before being on anti-TNF. So in the absence of reliable clinical predictors, we continue our patients, and in my view, we should develop studies. We should only withdraw drug in the context of a study that helps us at identifying patients at risk, and maybe that the endoscopy or lesions, endoscopic lesions or CRP are not enough, and we should work more now when we are working on that, on gene signatures, on really looking at the molecular, which is the activation, the state of activity of the disease at the molecular level. That might provide better predictors than just looking at lesions or even at histology, which is a very gross, very imprecise evaluation of the activity.
The time is limited. May we proceed to further questions, please? Thank you, Dr. Shuja.
Good morning, everybody. Yusuf Gari, gastroenterologist from King Abdulaziz University Hospital. I have a question for Professor Federak. Do you see the combination therapy with different biologics is applicable, like, for example, combining Humira and azathioprine, as well as infliximab and azathioprine? Like, does the combination therapy apply to all kind of biologics, or is more with infliximab, according to your experience? Do we have to combine it even with Humira? This is a question number, considering that it's a human-derived biologics and the chance of developing antibodies may not be as high as in infliximab. And the other question is combining 5-ASA and prednisolone at the time of induction of remission in patients with moderate to severe ulcerative colitis, or would you delay a little bit starting 5-ASA later? Is there any synergism between the two? The final question is to Professor Schreiber. We have a major problem in the kingdom with tuberculosis, and the clinical presentation of patients with TB and Crohn's is very similar. And we have had cases that were diagnosed as TB and responded very well to TB treatment, and they had a non-caseating granuloma and biopsy. So we find in our experience that unless we see the acid-fast bacilli or have a positive PCR, even in the absence of chest X-ray, is a major dilemma to us. I myself have had at least 2 cases that were treated with biological therapy who failed to respond, and then our infectious disease colleagues took over, treated them with anti-TB, and they fully responded. And I'm sure some of the colleagues in the audience have had a similar problem. Do you think there is a parameter? I know that you don't have tuberculosis very often in your part of the world, but do you foresee something that might help us in differentiating these 2 groups of patients? Thank you.
I'll start. So, I mean, those are excellent questions, and we don't have a lot of evidence around it. I'll tell you what I think and what I know. So your first question was adalimumab, do you need to use combination therapy? We have way less data than we do with infliximab plus combination therapy. There is data from the United Kingdom and Simon Travis's group that suggests, again, better outcomes with azathioprine plus adalimumab. It's not a randomized controlled trial, and so I'm extrapolating that. Because of that, I use combination therapy with my adalimumab, and I'm awaiting future trials. The second question was in mild ulcerative colitis. Yeah, you can treat with 5-ASA and often bring it under control, and you don't need corticosteroids right up front. I think as it gets more severe, and then that becomes a clinical judgment, I combine a short course of steroids. It seems to bring that inflammation down much quicker and leave them on the 5-ASA. Do I start 5-ASA and my steroids at the same time? In general, I do. I know there's no data to say it's really synergistic, but I want the patient to become used to taking the 5-ASA and that it's important maintenance for life, and so I start them at the same time.
The last question, please.
Yep, this is an increasing problem, as you point out, infectious disease in general. First, tuberculosis. There is forms of intestinal tuberculosis which can completely occur without any lung infection. It's probably done by infected milk or something like that. The last case I've seen was a girl, 19 years old, again good health, coming from Nepal, and she has been brought into Germany with 6 months of age. So she has basically lived as a German, and suddenly she has intestinal tuberculosis, probably from the milk she drank when she was a small child. We rely a lot on molecular diagnosis these days. So acid-fast bacilli are complemented usually. The staining is complemented with PCR-based diagnostics, and that is usually helpful, as we feel. And at the moment, we are trying to actually develop more assays, because we do have an infectious disease problem which goes even much more beyond tuberculosis, and we feel that the molecular microbiology, I think, will be very helpful in faster diagnosis, more precise diagnosis. Culture or morphologic diagnosis don't work so well. And at the end of the day, sometimes you only can make the diagnosis still, even Germany, wherever, even the United States, I think, on the operation specimen. You operate a patient, you have a stenosing process in the terminal ileum, you work up the operation specimen, suddenly you see it's tuberculosis, not Crohn's disease. And that's also a reason why I think you should still consider the operation, especially of limited disease, as an important therapy, not just think about conservative therapy.
Last question, short question, please.
Okay,
because
just a quick question. Hani Jawa, gastroenterologist from King Abdulaziz University. So my question is actually related to starting registries. So this morning we heard from Dr. Al-Jibrin that how starting an IBD registry can be very challenging at the beginning. So I'm just very interested to hear so is it just enough to have a group of enthusiastic gastroenterologists to start, an IBD registry, or what kind of resources do you actually need? So, I'm sure here we can hear experiences from Germany, Canada, and Spain. Thank you.
Yeah, I would recommend you extremely highly to start a registry, not only a registry but also a biobanking program. For that, you need obviously, in addition to a physician who wants to drive it, an epidemiologist who helps you. You need also statistical support, and you need skilled nurses to give you the quality, to ensure the quality of the documentation process and to make sure the patients are followed. And then the patient becomes a key driver. Once the patient is enrolled, you keep the contact over the patient. Why should you do that? First, because there may be certain complications in the Arab health that are different than what we see in Germany or over in the United States. So I think you have to be aware of that. Then the courses, the directions to therapy may be different in your population. And finally, I think there will be a big point about genetics. The genetics of the Arabian population is fundamentally different from the genetics which we see in the Caucasian population, where all the data comes from. And when genetics is applied, for example, for making therapy or diagnostics better, which will come in the next 5 or 10 years, you need to know about the patients and your population.
Let me add, in Spain we have a registry. We started this 6 years ago. We have 19,000 patients now in the registry, and we have DNA and serum samples for more than half of those. And we came up with quite on an equilibrium, because if you have, let's say, a point information on the patient, this is only of limited help. You need follow-up of these patients and get track of these patients when they develop complications, which type of complications, and then you see whether you had predictors at the time with DNA or at the time your serum samples were taken. And you need to find an equilibrium between the amount of information that the registry takes and how reliable is it. The more amount of information you get, the less reliable it may be. And we came up with a quite fair solution that's being very helpful.
I just want to make one comment. I think because you're seeing this accelerated growth in your Crohn's disease, I think the kingdom here has a real opportunity to play a role in defining some of the etiology and cause around Crohn's. Yours are environmental and biobank. Dr. Bakari knows all about that. I think you can fundamentally make some real inroads into that research if you're interested. Okay. Thank you.
Thank you very much. Professor Schreiber gave me a website that you can get more information about it. That is www.popgen.de Deutschland. At the end of the session, I would like to thank the organizing committee, thank the audience,